From the University of Colorado Anschutz Medical Center. I'm Julie Swaney. I will be moderating this session today. If you would please put your comments or your questions in the chat. I will read those to the group for Dr. Wynia to address after his talk. And before I introduce our speaker, I do want to mention that our next Ethics Grand Rounds will be next month in February, and we will be addressing ethical issues in elder abuse on February 8th with Dr. Elizabeth Bloman. So with that, I do want to introduce Dr. Matt Wynia, known to many of you for his excellence and in leading us in all things around bioethics. Dr. Wynia is the director of the Center for Bioethics and Humanities here at Anschutz Medical Campus. And he's also a professor at the University of Colorado School of Medicine. So thank you, Dr. Wynia, very much, and looking forward to your presentation on conscientious practice in healthcare.
Thank you so much, Julie. I really appreciate it. And I also want to proactively thank Sue Clifford, who's going to be managing my slides today since I'm having Zoom difficulties and can't share my screen. Sue, can you go ahead and put up the first slide? And while you're doing that, I will say also that while some of you know I've written a bit about this, I've actually never given a talk about this. So this is a brand new talk for me, and as such, I will beg your forgiveness if my timing isn't just right, and I will also ask for feedback, not necessarily for the whole group, but please feel free to send me comments or ideas about how to make it a better talk at the end of the session. So, this is, we're going to talk today about conscientious practice in healthcare, and I'm going to look at it both from the perspective of one's conscience telling them that you cannot do something that is otherwise either allowed or even required, or that you must do something even though there is a rule that in one way or another makes it more difficult or even prohibits it. So on the next slide, I believe it's just my learning objectives, which you've all seen, and so because they're in the invitation for this session, so I won't go over these. Go to the next slide, please. I also don't have any financial disclosures to make. I will say, by way of a general disclaimer, that I direct a Center for Bioethics and Humanities, which includes people with a variety of perspectives on this and many other issues. And so just the fact that I say something does not make that a position of our center, nor, by the way, of any other organizations with which I'm affiliated. So on the next slide, we'll start with a little case here, and this is a real case. Kathleen Pultz and her husband are parents of 4 from Milwaukee when in 2005, they decide that they don't want to have any more children. 4 is enough. And then they don't decide that they want to stop having sex. So when the condom broke during sex, she calls her doctor. She gets an urgent prescription for Plan B, which at that time required a prescription. She brings it to her local Walgreens, and the pharmacist, who is himself a devout Catholic, says, "I cannot fill this prescription." So if you, whoops, we just left the, there we go. So if you just click one more time, hopefully it'll go to the question here, which I'm not going to ask people to vote on this, but just in your mind, think, is that kind of an action, refusing to fill a prescription, is that a reasonable exercise of that individual's personal conscience? It obviously is going to have an effect on Kathleen and her husband. It may have an effect on others as well, but it's something deeply held by that individual not to participate. So questions here might involve things around, does that count? Does filling a prescription count as being a participant or as being complicit in the act which the pharmacist believes is an illicit act? So just keep that in your mind, right? That question. And then let's go to part 2 here on the next slide. So part 2, same questions, but this also happened. The pharmacist also said, not only will I not fill your prescription, I am not going to tell you where else you could go to get this filled. I'm not going to call one of my colleagues to fill it, and I'm not going to tell you where you can go outside of this pharmacy to get the prescription killed. And this is an actual quote. That would be like saying, I don't kill people myself, but I'll send you to someone else who does. So this notion of complicity in what the pharmacist conceives of as the potential murder of a fetus, a child, is that a reasonable exercise of personal conscience? Refusing to tell her where so refusing to refer her somewhere else where she can get this otherwise legal service, but one that the pharmacist believes is wrong. And if that is also reasonable, then I would extend it one more step and say, which also happened. The pharmacist also said, and this is an era of paper prescriptions, but the same thing happens with e-prescribing. He would not give the prescription back to her. He confiscated the prescription because he said, if I hand it back to you, that would make me complicit in the potential murder of a child. Is that also a reasonable exercise of conscience? And you could actually, envision additional understandings of what complicity means to extend beyond this, right? What if the pharmacist had said, now that I know you are trying to murder this child, I need to lock you in the pharmacy. I'm not going to let you leave until 9 months is out and you've had your baby, or until we're certain whether or not you're pregnant, since there was not certainty. As it turned out, by the way, she was not pregnant. But this is the sort of dilemma in its various permutations, going from something that, seems pretty reasonable to eventually you can get to a point where whatever the action is, almost everyone will say, okay, that is unreasonable. But we all are going to have different breakpoints along that understanding of what complicity and participation means. Next slide, please. I think we can't start this conversation without at least acknowledging that there is not a uniform definition of what conscience means. So we should say how people think of this phrase, or of a conscientious objection. What does the conscientious part bring to that? There are obviously religious connotations to this. My own faith background is of Catholicism, and the Catholics, we Catholics have given a lot of thought to what conscience means. A lot of people talk about conscience as that still small voice within us, right? The idea that there's something deep inside that tells us what the right thing to do is. The Conference of Catholic Bishops call conscience a, quote, judgment of reason from the Catechism back in the 1700s. But they also say that it involves the strict following of religious commandments. So it's both an exercise of personal reason and also the following of reasons or thinking that has come before. It's some blend of those two things, which is actually interesting in terms of the etymology of this word. Conscience comes from conscientia, which means both knowledge, and which is with. So it's the sharing of knowledge. And that raises questions, of course, both of where did you get that knowledge? What counts as knowledge? So there's that level of question. And who are you sharing this with? And in general, conscience has meant, in sort of colloquial terms, sharing of knowledge with yourself, because it's the idea that you have, the angel and the devil speaking to you from you. But the knowledge source could be, the culture in which you're raised. It could be the parents that you had. It could be your religious training and education. It could be science. It could be any number of things that are informing your sense of right and wrong. But it is always related to introspection and awareness of values and duties. So conscience and mindfulness bear some similarities. Conscience and conscious are etymologically related. In fact, they were essentially the same word apparently until about the 1700s. But the idea that conscience is the conscious awareness of something that is otherwise within yourself or hidden. It's sort of bringing that to the fore. So next slide, please. This raises questions about why we should protect the sense of conscience of individuals in a democratic society, right? In a democracy, we have ways of deciding what's right and wrong, which is to say we vote and we follow the majority. So why not say that, once the majority has voted, that's what counts as right. And if the majority, some minority disagrees that that's what's right, too bad for them. They have ways that they can change social policy so that what used to be right is now wrong. Why should we allow for individuals to operate outside of the mainstream or the plurality, the majority? And there are a number of good reasons why we have tried to protect conscience rights within the US. There is, of course, the general sense that we value individual liberty, that we value maintaining personal integrity. But there is also the sort of social justice ideal that it is valuable to society for people of good conscience, by the way. I haven't told you what good means to me, but for people to be able to protest and eventually reverse unjust laws. And that one way of exhibiting a protest is to say, I won't follow that law. And we give people that latitude because we want to maintain a society with diverse values and diverse attitudes, a diversity of moral codes. This was core to the creation of our nation, of course, especially in the sense that we wanted to avoid the creation of a state religion, right? Of a government-enforced religion. And not having a government-enforced religion means allowing people some latitude to make their own decisions about what's right and wrong. There are, of course, considerable risks that allowing too much latitude, that conscience rights can become this extremely expansive sort of trump card. Well, you all may say that, but I disagree. Essentially, everyone becomes a law unto themselves. And that's especially true if you start allowing for protections against becoming complicit in someone else's bad deed, right? So it's once you start saying, well, I can't do this because it allows you to be able to do something that's bad, that is a particularly large expansion of conscience rights because it allows almost everything to fall under the notion of conscience. And yet, there are good reasons for protecting people against the sense that they are becoming complicit in someone else's bad act. Legally, of course, being guilty is not just associated with doing the bad act yourself. You can be guilty of taking part in a crime by aiding or abetting or helping someone to carry out that crime. So legally, we see complicity as related clearly to bad things, and morally. We also see this. I put up here two quotes, one from Gandhi, one from Martin Luther King Jr., both reflecting this sense that you have a moral responsibility to argue against things that are happening that your conscience or your religious faith background tell you to be wrong. So there are reasons why we don't want to force people into doing things that make them feel that they are complicit in someone else's bad act. So next slide. This has mostly shown up in the sense of conscientious refusal to participate, rather than the I insist part of the title of this talk, which we'll get to in a few minutes. On the I object side of this, on the conscientious refusal side of this, conscientious objection or conscientious refusal is essentially a refusal to follow some rule or requirement on moral or religious grounds, on grounds that your conscience, however derived, tells you that that is illicit. The obvious examples of this, the ones that we have many, many examples of, are refusals to participate in abortion or in helping someone to obtain birth control or assisted dying. It also, though, shows up in the vaccination debates. It shows up certainly in the care for LGBTQ individuals. It also shows up in the sense that early on, for example, there were states that required physicians to participate in capital punishment. Physicians, by and large, had said, no, we won't do that. That's contrary to our code of ethics. And so that is a conscientious, that was a, there are not states that require it anymore, but that was an issue of conscientious refusal. Same thing with coercive or torture interrogations, where I only know of one example, but there was at least one individual who said, no, I will not participate in that. And that would be a conscientious refusal as well. Conscientious refusals always impact someone else in one way or another. So they're never just about your individual liberty. They're always about balancing your individual liberty and the rights that others hold. And this concept of complicity is extremely important. It's extremely potentially expansive. And eventually, the complicity arguments merge into the sense that you have an obligation of advocacy, which is to say, some people feel that they are complicit if they fail to advocate that no one should be able to have an abortion, right? That the same thing that drives them to say, I would never do that myself, also drives them to say, and I don't think anyone else should be able to do it either. So complicity is a remarkably expansive concept. Next slide, please. There are many historical and contemporary protections for people who want to object and not participate in some aspect of civic life that is otherwise required of everyone else, but this person wants to opt out because it goes against their conscience, or this group wants to opt out because it goes against their conscience. These are just a couple of the founding fathers and their reflections on, the importance of sustaining a sense of conscience and of protecting that the rights of conscience against what Jefferson called the enterprises of the civil authority, meaning the state, the government. Next slide, please. In recent years, these protections had taken the form of a number of federal laws. So right after Roe v. Wade in the 1970s, the church amendments were enacted to protect the conscience rights of both individuals and organizations that did not want to be involved in performing or assisting in performing abortions and sterilizations. And then in the wake of this really interesting case that I have another slide on in a second, the Religious Freedom Restoration Act required that any time a federal law applies to a religious group of any kind or a religious individual, that the government should not substantially burden that person's exercise of religion, even if the burden results from a rule of general applicability, unless it is the least restrictive way to accomplish a compelling government interest. So this is the definition of what strict scrutiny means under a law, and it essentially makes it extremely difficult to defend any law that that impacts anyone's religious faith. It makes it very challenging to sustain those laws. They're very likely, after the Religious Freedom Restoration Act, those laws were very likely to be rejected as unconstitutional. And this is why, by the way, we've seen a series of subsequent decisions. So the quick history on the Religious Freedom Restoration Act is that Alfred Smith and Galen Black, indigenous people from in Oregon, were fired from their work at actually at a drug rehab center because they were found to have mescaline on their drug test. They had performed a religious ritual, or had been involved in a religious ritual using peyote, and they were fired and also denied unemployment benefits by the state of Oregon, because the state of Oregon doesn't pay unemployment benefits if you are fired for an offense like that, a drug-related offense. Both the Supreme Court of Oregon and the Court of Appeals, in the other order, first the Court of Appeals, then the Oregon Supreme Court, disagreed. They thought that Oregon ought to pay the unemployment benefits to Galen and Black. The Supreme Court, however, agreed and said the state of Oregon was allowed to withhold their unemployment benefits because the ban on granting benefits for this offense was a neutral ban. It wasn't targeting a religion. It was a generally applicable ban that applied to everyone without regard to their religion. And the Supreme Court said that we should not have the strict scrutiny standard for laws that affect religious practice, because if we did, everyone would become a law unto themselves, right? That it would lead to anarchy, that everyone would say, I don't want to obey that law, it's against my religious faith, and they would get out of it. And this would open, as they said, this, by the way, is Scalia. So this would open the prospect of constitutionally required religious exemptions from civic obligations of almost every conceivable kind. This case was incredibly controversial, and it brought together the religious freedom folks on the far right and those who wanted to see protections for indigenous people on the left. And the Religious Freedom Restoration Act, which reversed this Supreme Court decision, was passed almost immediately in response to that's why it's called Restoration Act. It's to restore the sense of religious freedom, that even people, who come from smaller religious groups, who have faith beliefs that are outside of mainstream faith beliefs, that those people should be protected just as the mainstream faith believers should be protected. And so the Religious Freedom Act requires that strict scrutiny be applied. So it reversed essentially the Smith decision in many cases. A subsequent case, by the way, removed the applicability of this to state law. So this is only for federal purposes. Next slide, please. On top of these, there are a slew of additional federal protections, and I won't go through all of these, but only to say that, over and over again, there have been instances where the federal government has essentially said, we are going to protect people who do not want to be involved in specifically abortions or abortions and medical aided dying, or or a variety, reproductive, et cetera. So we won't go through all of these. Next slide, please. In addition to federal protections, there are state level protections for conscience in many, but not all states. And so this is a slide from the National Women's Law Center that just shows in color coding those states where pharmacists are allowed to refuse to dispense prescriptions that they disagree with for religious or moral reasons, and to not transfer that prescription elsewhere. So requiring essentially that the person go back to the doctor and get a new prescription in order to bring it to a new pharmacy, or back to the doctor to have the doctor re-prescribe it and send the prescription to a different pharmacy. The blue states require pharmacists to provide medication to patients. So they do not allow for conscientious refusal to fill prescriptions. They have basically said that doesn't count as participation in the act. So whether you agree or disagree with abortion or birth control, you must prescribe those if you're going to be a licensed pharmacist in our state. And we, disagree with you. That does not make you a participant. So, just set that out there. The green ones are not state laws, but state pharmacy boards. And basically where state boards have approached this, they have essentially said pharmacists are allowed to refuse, but they're not allowed to obstruct patient access to medication. And so they look at these on a case-by-case basis. And they would say, in some cases, a refusal is an obstruction. Say, if you are the only pharmacist in a 50-mile radius or a 20-mile radius, or for that particular patient, it was an obstruction because of the nature of the condition, how quickly the medication was needed, the time of the day, et cetera. So they will look at these in a case-by-case basis and say, is that an obstruction or is that a conscientious refusal that's allowable? Next slide, please. In 2017, the Trump administration, I believe it's 2017, created a new office in the Office of or a new division in the Office of Civil Rights of the Health and Human Services Division called the Conscience and Religious Freedom Division, that was tasked with looking specifically at these conscience rules and with putting in place some federal conscience rule that would bolster what was already in place. So there were already, this was already part of the work of the Office of Civil Rights because of those things like the Church Amendment. So the Office of Civil Rights was already looking at this and already had enforcement mechanisms. But the Trump administration proposed essentially an absolute right of conscience, meaning that employers, say of pharmacists, had to allow any employee, so not just pharmacists, not just doctors, not just nurses, ambulance drivers, food service workers, anyone could decline to participate in any way in the care of a patient who wanted to get a procedure or needed to get a procedure that that individual felt was illicit or wrong. Even if not allowed, their opting out of participation was an undue hardship, even if the employer offered religious accommodations that that courts would deem reasonable, that would not be enough. They had to offer a complete right of opting out, and the penalty, if you failed to adhere to this new rule, would be the loss of all HHS funding for a single violation. So all Medicare, all federal Medicaid dollars would go away if you were found in violation of this a single time. It was put in place in May of 2019, but by November it had been it had actually been vacated. It was eventually vacated by, I think, 3 different courts. And on the next slide, you'll see that when the Biden administration came in, they started reworking this. And the reworked rule was released yesterday. So I'm not going to go into this in detail, but it looks quite a bit like the 2011 rule. So it is not this absolute right. It's a more, what I would say, more nuanced in the sense that it considers both the rights of patients to access medications and the rights and procedures and so on that are legal in the state in which they live, and the rights of health professionals and others providing the care to maintain their conscience. So it sort of recognizes, I think, the balance that has to be in place here, in the sense that there are competing rights at issue. Next slide, please. So that gets us to this one, which is the I insist. And this is really another form of what you might call civil resistance in medicine. Civil resistance is generally defined as nonviolent. That's what makes it civil. So as opposed to uncivil or violent protest, civil resistance are nonviolent ways of objecting to laws and rules or conditions that you think are wrong. And the intent of this is to change the law, to change the rule, to change the code of ethics, to change the condition, the social condition that you think is wrong. So civil resistance is a broad spectrum of activities. It runs the gamut from, writing strongly worded letters to your legislator, to organizing protests and marches, to writing your own legislation and trying to get it passed, media strategies. But it does also include, at sort of towards one end of the spectrum, actual disobedience of the rule. Right? So civil disobedience is a part of this spectrum of ways of trying to get the law to be changed. This is actually addressed in the Code of Medical Ethics of the American Medical Association. It's been in there for many, many years, in the section that looks at what's the difference between law and ethics. And what the AMA says is that the law sometimes might mandate conduct that would, under professional ethics, be unacceptable. And when physicians believe a law violates ethical values or is unjust in terms of their medical professional understanding of what justice means, then they should work to change the law. And in exceptional circumstances of unjust laws, ethical responsibility should supersede legal duties. This sounds, by the way, very much like Martin Luther King Jr. It sounds very much like Mahatma Gandhi. Next slide, please. So it's not exactly, saying physicians to the barricades, we're going to break the law, but it certainly recognizes that that could happen. Before I talk about that, though, I really need to acknowledge what I started with, and in terms of this section, and Katie Watson's amazing work in this space. If you have not read Dark Alley Ethics from the New England Journal last March, you should definitely pull this up. She just makes the incredibly important point that because you think something might be prohibited under a vague, nebulous statute does not mean it is prohibited. And she, is trying to be sensitive to physicians who really feel, as she says, caught between a patient in crisis and the threat of criminal penalties if you manage that crisis in a way that some legislator or local DA thinks is a bad way, that you may end up in their crosshairs. But she says, really, it is up to the medical profession to understand that these laws do not make most medical care illegal, even if they are unclear. Our obligation is to practice medicine bravely. She says that's no small thing, practicing medicine bravely, but it is not civil disobedience. And it's not covert law breaking. In fact, she says it's not even civil resistance. The fact that we are being forced to walk down this dark alley where we're not sure where the danger might lie in our actions is a reason for us to act like the advice that women are given when they have to walk down a dark alley, which is don't act like a victim, right? Walk tall, act like you belong there, walk with a friend if you can. And she gives a series of recommendations for how to move forward, protecting women, doing our jobs under circumstances of legal uncertainty. So I just want to put that out there and make sure that you're all aware of this, because it's very important perspective. We do not necessarily have to break the law in order to challenge these circumstances. Next slide, please. So conscientious provision of things that are otherwise forbidden or discouraged on moral or religious grounds is also a part of this talk, I think. You can't really talk about conscientious practice and only talk about those parts of medical practice that you refuse to do. You also need to talk about those parts of practice that you are compelled to do by your professional responsibilities. This has been around for generations. There were papers about this in the assisted dying literature back in the 80s and 90s, including surveys asking doctors about how often do you assist patients in the dying process by giving them something that might hasten their dying. And a fair number of doctors said that they did that, even though it was clearly illegal at the time. Same with abortion. Same with transgender care today. There are people who do feel compelled to provide care to patients or ongoing care to patients, despite the fact that doing so is explicitly being made illegal or being discouraged in some way. I'll also say, by the way, you could put under this those physicians who do participate in capital punishment now, even though that is contrary to professional codes of ethics, or those physicians who participate in torture, or nurses who participate in torture, even though that is contrary to professional codes and the law. You could also put under this conscientious provision people who feel compelled to give patients hydroxychloroquine or ivermectin for COVID on the honest belief. So now I'm not putting, someone in that category who is a quack and just doing this, to make money. But if you honestly believe that this is a miracle drug, then you would say, this is my conscientious duty to provide this to patients. And by the way, in some way, you could say the same of all off-label drug use. All of that is based on our professional responsibility to use the best information available to treat patients in the best way we possibly can, even if the drug is not formally approved for use in that circumstance. It's not all of these are on a spectrum, right? Because just not being approved doesn't mean it's disapproved. So we're allowed to use things off-label. We're not disallowed. But it's the same general thought process of my obligation is not to just follow what's written down in the rules. It's to do the best I can given what we have. Like conscientious refusals, conscientious provision of healthcare also impacts patients. So it too is never just about individual liberty. It's about society as well. So it also has this. And in this instance, the key concept is not so much about complicity as it is about professionalism. There's a difference between I insist, I personally believe this is the right thing to do, and we insist. Because we insist, as a professional group, mitigates some of the potential risks of conscientious provision. Next slide, please. Whoops, other way. There we go. There are, as we said before, a number of risks of civil disobedience. And these are also true, as I note at the bottom, of conscientious objection. So these are the risks of people not obeying the rules, right? Like there are rules, and the question is, in a democratic society, should you follow rules with which you disagree? You think it's a bad rule. Should you follow it anyways? This was a large part of the subject of the famous Lincoln-Douglas debates. And by the way, if you haven't ever, or you haven't since high school, looked at the Lincoln-Douglas debates, it's really worth going back to these because they really describe very well the sort of pros and cons of personal liberty, moral conscience, the right to protest bad laws, the importance of respect for minority rights, that democracy doesn't always lead to justice, versus, and so those are reasons why you should be able to disobey bad laws and protest them in a variety of ways, versus the need to maintain rule of law and civility, the ideals of a social contract, the respect for majority decision-making in a democracy. That was Lincoln's side in this debate, by the way, for those who don't remember high school civics. Lincoln took the side of you should obey bad laws. Until you can overturn them, you should obey them. And Douglas took the side of personal liberty, and individuals and groups should have the right to reject bad laws out of hand without going back to the legislature to get them fixed all the time. There are obviously risks for the individual who is disobeying a law and for those who rely on them. This has come up in the context of the abortion conversations recently. If, in fact, the few people who provide abortions were to start getting arrested, this would not just affect those individual doctors, although it would certainly affect those individual doctors. It would also affect all the patients that they care for. And this has been one of the reasons why you have not seen a wave of doctors rising up to practice civil disobedience in response to the Dobbs decision. Finally, what Lincoln said is that this well-functioning democracy that we have provides us with alternative and better strategies for changing laws. That civil disobedience, explicitly disobeying laws in order to call out their injustice, is not the best way to change the law. And then there's, of course, there's Justice Scalia's argument from the Smith decision that if we start allowing people to disobey laws on the basis of their individual moralities, that makes each person a law unto themselves and creates anarchy. Next slide, please. So how do you mitigate these risks? Well, one way is to not do it, right? So this is the quote from Abraham Lincoln that I like to use from his Lyceum address, which is well before the Civil War, but he's basically saying, look, of course we should fix bad laws, but if there is a law in force, even if you think it's a bad one, you should observe it religiously for the sake of example. You want everyone to see that we are a nation of laws, that we are people who respect laws. Those who have looked into the idea of conscientious objection the most deeply, and I've got just 2 examples here, but there are many others, take very seriously the possibility that people could overdo the right to nonviolent civil disobedience. MLK goes through not just these, but a number of other steps in terms of ensuring that if you are going to practice civil disobedience and decline to obey a law or break some other law in order to call attention to the injustice, so either direct or indirect civil disobedience, both of those require an extensive deliberative process within yourself and preferably within a community of people. Gandhi famously actually undertook some of his longest hunger strikes were not against the government. They were to rein in his own supporters who were moving from civil to uncivil disobedience, and he was trying to call them back to be more civil in their resistance efforts. And of course, you all know he was eventually killed by one of his own supporters who did not like the non-violent ways that he was proposing that the partition was supposed to, around the partition of India into India and Pakistan. Next slide, please. One of the things that I have proposed in this space is that professional civil disobedience is different from individual civil disobedience, because professions arise around the need to protect vulnerable individuals and vulnerable values, that we have a role as professionals in seeing when society is going off track and is starting to harm the vulnerable people that we are charged with caring for. And so far from the idea that civil disobedience might lead to anarchy, professional civil disobedience that is organized by a professional group that is sanctioned by society as the protector of a set of values and vulnerable individuals, that type of civil disobedience might actually, or civil resistance, let's say, that type of civil resistance might actually repair rather than tear apart the basic fabric of society. The notion of a nation that is ruled by laws and shared norms. Next slide, please. So in order to understand that argument, and I realize I am probably getting close to time, so I'm going to do this really fast. To understand that argument, you really have to know a little bit about at least the way I think of professionalism, which is to say there's a common way of thinking about professionalism, which is it's a set of principles or commitments, things that we have promised, and that's professionalism. Next slide. This list approach, I think, these are important attributes. They are the things that show up in our codes of ethics, but they're not professionalism per se. And if you click one more time, professionalism, I don't think it comprises the things we do. It's the reason we do them. And this derives from the idea that professionalism actually can be understood best by understanding its etymology. So next slide, please. And this is going to build, so just click this a few times and we'll get to the end. So profess means to speak out, to openly declare. A profession is a group of people who speak out together about their shared standards and values. So a professional is a member of that group. As an adjective, professional means acting in conformance with the shared standards and values of the group. And adding ism to professional makes it an ism, a belief system. So professionalism is the belief system, the understanding that professional groups are uniquely well suited to organize and deliver certain social goods. Click one more time. What this means is being a part of our profession and professionalism requires us to establish our practice and ethical standards and to ensure that we all are adhering to those standards. So next slide, please. So that leads to this set of questions about what are professional standards for and what does enforcing professional standards entail? What's the relative weight of a professional ethical or practice standard in comparison to the law or compared to a religious doctrine that one might also feel is very important? It also raises the question of, is health professionalism, does health professional ethics give us a set of beliefs and values about what's right and wrong that we might hold as strongly and sincerely as anyone else might hold their religious beliefs? Does it count as a set of strongly and sincerely held beliefs about what's right and wrong and how society ought to be organized? And what should we do as a group? Not what should I do, but what should we do as a group when a standard of medical practice is made illegal? What if a law or a doctrine demands that we harm a patient? Next slide, please. So we're getting towards the end here. This is the encapsulation of this dilemma, which can arise across multiple dimensions, right? But the basic notion is that we have these professional responsibilities that include putting patient interests above our own. We have professional codes and practice standards that we have essentially signed onto in one way or another. And we recognize that our profession is oriented around vulnerability and the potential for stigma of the patients that we serve, the people who are in a position of social vulnerability, and that our primary task is to protect them versus religious liberty, personal beliefs, individual integrity, or, as I said before, putting the law or other demands into this mix. Next slide, please. I do want just one quick note here because this comes up a lot in conversations about this. We withhold services from patients that they might want all the time. You know, anytime someone comes in initially thinking they want an antibiotic or they want an opiate or they want a CT scan, and we eventually say that's actually not going to be clinically warranted in this circumstance. How is that different from conscientious refusal? Well, in some ways, some conscientious refusers say it's not different. It's the same, because the object of my objection, whether it's abortion or aid in dying or care for transgender individuals or vaccinations, those do not have clinical value, or they don't have enough clinical value to warrant the harm that they might cause, right? So maybe they have clinical value for the pregnant woman, but they're going to harm the fetus in a way that makes this a medical decision, and that it is medically unwarranted. So, and there are others who, by the way, say none of those are medical interventions at all. That medical aid in dying is not a medical intervention by their definition of medical intervention. So there are those who believe that there is no difference between a clinically unwarranted action and a conscientiously unwarranted action. The way in which they're different is that clinically based refusals have the intent of protecting patient and patient health generally. But patient rights are definitely harmed, right? So if a patient says they really want something and you say no, if the reason you're saying no is to protect the patient, you're being paternalistic. And that patient's dignity and, you know, their rights, I haven't defined rights here, but their dignity is being harmed because you're telling them no, they can't get something, even if it's for their own good. But the point is, it's about their own good. Conscience-based refusers are generally not thinking primarily about the good of the patient per se. They may be protecting the baby. They may be protecting their own moral or religious integrity. But in general, they're not looking out solely for the well-being of the individual patient. They have other things coming into play. And in these instances, of course, both the patient rights and patient health may be harmed. Maybe a little bit harmed, maybe a lot harmed, depends on the circumstance. Next slide, please. This gets us to last point about religious belief. And as you all will recognize, religion is deeply ingrained in this conversation about what counts as a conscience right. There is a definition of what counts as a religious belief that is used by the Office of Civil Rights. It includes not just traditional organized religions. It could be new, can be uncommon. It can be subscribed to by only one person. Or so a belief could be a religious belief, even if only one person believes it, and it doesn't have to be logical or reasonable, and it doesn't have to include God. So both theistic and non-theistic beliefs can be religious as long as they are moral or ethical, and as long as they deal with what's right and wrong, and they are sincerely held with the strength of traditional religious views. So they have to be about ultimate ideas of life, purpose, and death. Next slide, please. This gets us to questions about whose religious liberty. There have been a series of lawsuits filed in Florida now claiming that, for example, Jewish belief that abortion is required when it's necessary to protect the health and either mental or physical well-being of the woman. And therefore, a law precluding abortions violates Jewish belief systems. And it imposes the law of another religion on their religion. And it curtails clergy members' ability to counsel their congregants. And it's not just Jewish people, of course. The United Church of Christ, Unitarians, Episcopalians, Buddhists have all filed suit saying that Florida's abortion ban violates their religious rights. Next slide, please. It also raises this question of, should we think of health professional ethical responsibilities as religious duties? I think by the definition given by the Office of Civil Rights, these are certainly, they can be strongly held, sincerely held. They are about right and wrong explicitly. The code of ethics is all about right and wrong. So it is very hard to see what the difference is between a religious belief as defined by HHS and what we consider to be our professional responsibilities. Next slide, please. So our policy options are around transparency. At minimum, it seems patients deserve to know what the belief systems are of the people who are taking care of them, both individually and as organizations. That is an enforceable policy option. You can make sure that if you are going to a hospital that does not offer certain services, that information is easily accessible. This is not easily accessible today. Lots of data on this. It is hard to find out often when a hospital or health system does not participate in any number of different things where they may say, based on our organizational religious beliefs, we will not participate, nor is it clear what level of refusal they're talking about. The other thing is mutual respect, recognizing that there should be equal protection for rights of conscience, both for those who are trying to adhere to medical codes of ethics and those who are trying to adhere to their personal religious beliefs, that these are equally deserving of respect and dignity. And the only way to do that is to think about this at the organizational level. Only organizations, I think, can navigate respecting patient rights while also respecting staff conscience rights. And I'll just, in the last slide here, say, you might wonder, so why would religious believers accept transparency and mutual respect and access as things to move towards when their current approach to policy change seems to be working? Next slide, last slide. I think, sorry, you know what, let me just stop there because I realize I am first time I'm giving this talk, it's too long. That's lesson number one. So we'll stop there, and I think we have too little time for Q&A. I apologize for that.
Well, thank you, Matt, very much. There are a number of really good comments and questions. One question that has come up is you've mentioned multiple times about the various codes of ethics that people take. There really are competing moral obligations, particularly in healthcare, and healthcare workers have competing moral obligations and codes of ethics. What is your advice on how people would prioritize the various codes of ethics to which they subscribe, as well as their individual conscience?
Yeah, I think that's, that is sort of at the core of all of this, is there are competing obligations and competing responsibilities and competing potentially ethical values. If you are a member of a church and a member of a profession and a member of a family and a member of, a social community, you're going to end up having to navigate all of those and make some choices about whether you take your professional responsibilities seriously enough to mitigate the sense, that you cannot, for example, participate in someone else's act that, you may not approve of that act, but you're willing to take care of them anyways. By the way, we do this a lot in medicine, right? We take care of people whose actions we wouldn't do ourselves quite often. Where we may feel that what they're doing is wrong, they shouldn't be doing that. That doesn't mean that we want to make that action illegal. It doesn't mean that we want to, not help them. So I don't have an answer to that, obviously.
Right.
Each of us has to navigate these competing demands. And what I would urge is the idea of mutual respect.
Dr. Wynia, you just mentioned anarchy, which is a form of society where the rigid state replaced with a stateless society based on voluntary free association. I always wondered if it is not, I'm sorry, not the common secular morality, which proposed by principalist ethicists is a form of anarchy due to its low sensitivity to cultural differences. Please comment.
Common secular morality is a form of anarchy.
Wondered if the notion of common secular morality is a form of anarchy.
I mean, I guess I would doubt that anything is anarchy if it proposes that everyone ought to or does hold a similar set of norms and values. Because anarchy implies that each individual is creating their own set of norms and values to which they will adhere. And the only relationships that matter are those that individual chooses to enter into. So there's no state, right? It's individuals. But if you're proposing, if the idea of, common secular morality is that there is, in fact, a common set of things that we all actually agree on, then you're proposing that anarchy, in some ways, you're proposing anarchy can't exist because we already hold this shared set of norms. I don't know if that's a satisfying answer to the question. Probably not.
Many great many great philosophical points, if not theological, certainly philosophical points here that are terrific. And I am aware of time. There are some really great comments, legal and otherwise, in the chat. Thank you so much, people, for your perspectives on this. And I encourage everybody to really read through those and ponder them. This has really been great, Matt. You've pulled together a lot of really complex issues into, I think, a very coherent presentation, and we really appreciate it. It comes up day in and day out. And as you started by saying it, it's nuanced, and it comes up in so many different ways, particularly in our society, for better or worse, and I think probably for better. But nevertheless, there it is. So thank you very much again, and it really was great. Again, I wanted to let folks know that February 8th, our next presentation will be Dr. Elizabeth Bloman speaking on ethical issues in elder abuse. So thank you again. Really appreciate it, Matt. And hope to see you all next month.
Take care all.